Hello, good morning to all. I am Prof.Manavalam. Today we are going to see about the interesting topic APH, antepartum hemorrhage. Normally everyone known very well that is pregnancy is a joyous experience experienced by the mother. It is a short-term journey of every mother's life. During this journey, however, the mother is having the joyful experience. At the same time, mother also encountering the uncertainty as well as challenges. In one such challenges is APH, antepartum hemorrhage. It is commonly occur during the after 28 weeks of pregnancy. So antepartum hemorrhage, it is nothing but the bleeding that occurs from the genital tract after 28 week of pregnancy, that is called as it is one of the major reason for antenatal mortality and morbidity. So there are different causes are there for antepartum hemorrhage. In this, the placenta is playing major role. So in this placenta, there are two type of causes are there: placenta abruption and placenta previa. So in this slide, first we are going to see about the placenta previa. Actually, the first picture, it shows the how the normally placenta located. Normally the placenta located in the upper uterine segment. Instead of locating in the upper uterine segment, sometimes the placenta which will be located or lying down partially or completely in the lower uterine segment covering the internal os. That is called as a placenta previa. So placenta previa is nothing but the placenta lying in the lower uterine segment partially or completely, it is covering the internal os. There are many different types of placenta previa are the low-lying, marginal, partial and complete. Low-lying placenta previa, in this major part of the placenta lying in the upper uterine segment, only some part, a minimal part of the placenta lying in the lower uterine segment but does not cover the internal os. Marginal, margin of the placenta covering the edge of the internal os. Next partial placenta, part of the placenta covering the part of the internal os. It is partially covering the internal os. Complete. Here completely the placenta lying over the internal os. It is one of the complicated type of placenta previa. Next we will move on to the management of placenta previa. Most of the placenta previa doesn't have the mother doesn't have the bleeding, but sometimes mother may have the bleeding and pain, experience of pain may have. So all APH, most probably the placenta previa patient should be admitted. After admission, immediately as a midwife we have to do the general and abdominal examination. While doing the abdominal examination, we should not disturb the placenta, but we have to check out the pain, whether the mother is having the experience of pain, abdominal tenderness, that we have to ensure that. Next we have to do the clinical assessment of blood loss by checking the vital, monitoring the vital signs, and we have to look after the symptoms of hypovolemic shock. Next we have to do the basic investigation like hemoglobin, hematocrit, as well as the mother doesn't have any blood grouping typing already not yet done means we have to do that one. So if needed means we have to do the resuscitation procedure, or else we have to no need of bothering about that. We have to start to infuse the IV fluid in order to stabilize the mother condition. If needed, we have to get ready for blood transfusion. After that, we have to locate the placenta by using the ultrasound. There are two different types of different way of we can treat the mother. So the first one is expectant treatment and active interference. Some of the mother, they doesn't have any symptoms and correlating factors means better we can wait until the 37 weeks of gestation, then we can deliver by normally or either by cesarean section. In case of expectant treatment, the mother doesn't have the active bleeding, pregnancy is less than 37 weeks, the mother is stable, hemodynamically stable, the fetal heart rate is reassuring by NST, and also in CTG, the fetus is reactive means we can wait until 37 weeks of pregnancy. During this, mother completely admitted in the hospital, we have to continuous monitoring. We have to, and as a midwife, we have to continuously monitor the mother, and also we have to locate the placenta by using the ultrasound. Follow that in the other side, active interference. In case of the mother having the bleeding and the bleeding is continuing, mother more than 37 weeks of pregnancy, they are started to have the symptoms of labor pain has started, and also the FH is non reassuring or absence of they are not we are not able to hear the fetal heart rate. There is no gross fetal malformation to the mother, means we can start to give the steroid therapy, mainly corticosteroid. We can administer to the mother. It is mainly administered to improve the fetal lung maturity. After that, we have to assess the placental location. If the placenta edge is clearly 2 to 3 centimeters away from the internal cervical mass, means we can do the double set of examination. We can take the mother to the operation theater, and we have to have the setup for normal vaginal delivery and cesarean section. If while doing the examination, internal examination, the mother having the bleeding, means better we can take mother to cesarean delivery. If the mother doesn't have any kind of bleeding or symptoms of shock, means better we can wait and do the artificial rupture of membrane and infuse the oxytocin. If the continuously we have to monitor both the mother and the fetus by putting mother under CTG and monitors. If the satisfactory progress of labor is present, means we can wait for vaginal delivery and deliver the baby by vaginal delivery, or else if the bleeding is continuous, low labor initiation, means better we can deliver by cesarean delivery. In other side, the placental edge within 2 centimeters from the internal os or placenta previa more than type 1, means better we should not do any kind of internal examination, because we could not induce further complication to the mother as well as fetus. Better we can take the mother for cesarean section. So this is how we have to manage the placenta previa patient. I hope everyone understood about the placenta.